and good morning, good afternoon, or good evening, depending on where you're located. And welcome to this edition of the series of cyber webinars. Today, we have a very engaging and very interesting topic that all of us are going to be speaking about. My name is Dr. Praveen Krishna Vadavali, and I'm located in Hyderabad, India. And my colleagues today for this webinar are Dr. Nilima Balakrishnan, also located at Hyderabad in India, and Dr. Pallavi Joshi, located in Bangalore in India. We'll go through a more detailed introduction as we start their lectures. But the theme for today, evening, afternoon, or morning, whatever it might be, is going to be focusing on innovations in the detection of keratoconus. And unlike expectations about going through the run-of-the-mill session on reading topography and getting the lowdown on diagnosing keratoconus, we thought we'll approach this a little differently and focus on how keratoconus is transforming and what we've learned in the area of keratoconus over the last several decades. So I'm going to be starting the webinar with a brief overview of not just the diagnostic criteria for keratoconus, but also what has changed over the last several decades and what we could look forward to, and how keratoconus in itself is changing as a disease, and what skills all of us need to acquire to stay abreast. Following that, Dr. Nilima Balakrishnan will be speaking about a very interesting piece of work that she's been engaged in detecting keratoconus, not just in the clinic, but also in the field. Then we're going to have Dr. Pallavi Joshi speak about a new innovation that she and her team have put together in building a mobile handheld topography system that all of us can use in the not so distant future. So to get started, what I thought I'll speak to you today about is the experience that we've had with understanding keratoconus as a disease process over the last 30 years. And that is the reason why my presentation is titled Keratoconus 30 plus years. To start off, we're going to be talking a little bit about how keratoconus has changed over the last 3 decades that we've been paying more attention to it, how the future of keratoconus might be different from what we're aware of right now, what skills do all of us need as vision care providers to take care of our patients with keratoconus, and also where to look for the next keratoconus patient who might emerge into your clinic. So to start off, there is a popular slide that I'd like to share with my fellows and my residents. When they ask about keratoconus and the questions get deeper and more penetrative, there is a point that you have to stop answering the questions. Because it seems that, like most disease processes, there is a little that we know about keratoconus. There is a little that we don't know about keratoconus, and we know that we don't know. But there is an awful lot that we probably do not know about keratoconus, and we don't even know about it, or we haven't thought about it yet. And that is how I like to approach keratoconus, because this is an enigma that I think we're discovering as we go along. So to answer some of the questions about keratoconus, we're going to be talking about why keratoconus occurs, who gets keratoconus, where do keratoconus patients present, when does keratoconus actually present you in the clinic, how does keratoconus develop. But first of all, before we answer any of these questions, we're going to be talking about what actually is keratoconus. So, keratoconus, from the classical definition that all of us have been taught in colleges, and we continue to be taught in colleges or our medical schools, is supposed to be a non-inflammatory, bilateral, progressive, ectatic, degenerative condition of the cornea. That supposedly is the complete and full definition of keratoconus. But then again, if you think about it, A number of points in this definition have changed, especially in the last 10 years or so. Keratoconus is no longer considered a non-inflammatory condition. There are many patients of keratoconus who tend to have keratoconus only in one eye, and the other eye tends to be quite normal. All patients of keratoconus do not progress with time, and keratoconus is not a classical degenerative condition. It does have ectasia, but classically not degenerative. So, the only way in which you can answer that question is that you know keratoconus when you see it. And there are many ways of diagnosing keratoconus. The most obvious way is on slit lamp. The second most obvious way of diagnosing keratoconus is on corneal topography, which is going to be a major area of our discussion today. But before we start talking about topography, let's also examine what are the other modalities that are available for diagnosing keratoconus. Some of you, especially those of you who've been in practice for more than 10 years, would remember this machine called the ocular response analyzer, a machine that was supposed to measure the biomechanical strength of the cornea, and potentially a machine that came into the market before its time because it faded away very quickly as well. This has been replaced by more recent iterations of the same kind of technology. The current machine that is supposed to measure biomechanics is a machine called the Corvis, which inputs data from the Scheimpflug system as well as from a biomechanical air puff kind of machine, and it can give you some insights into who has keratoconus and who doesn't. There are other machines as well that seem to have become popular in the recent past, and one of them is the OCT. And the reason why the OCT has become popular is because it can measure corneal thickness as well as epithelial thickness. And measuring the thickness of the epithelium over the cone has become a popular way of trying to detect keratoconus a little earlier than it is seen on typical topography machines. In addition to this, there are several new technologies that seem to emerge every year, and also several new ways in which we can diagnose keratoconus. But the bottom line is keratoconus still is very much a clinical diagnosis and a topography diagnosis, because these are the two common pathways which are commonly available to clinicians everywhere in the world. You will hear experts speak about the new methods of diagnosing keratoconus, but their time probably hasn't come yet. And a very quick summary of the clinical features of keratoconus that all of us do pay attention to. All of you know about the blurred vision, the poor best spectacle corrected visual acuity, the typical history of frequent change in glasses, asymmetric refraction, and patients presenting with high cylinders as well. Classic textbook descriptions also have signs on external examination like the Munson sign, the Rizzuti sign, and the oil droplet reflex, details of which we will not go into today. But for the sake of completion, the slit lamp signs of keratoconus that include ectasia, thinning, prominent corneal nerves, pigmented ring called the Flesher ring, Vogt striae on the cornea, apical scarring, and in some cases, Desmais level scarring as well. So, how is keratoconus actually documented and diagnosed in the clinic? Well, one of the most common ways in which keratoconus was diagnosed and documented was using the classical keratometer. But then emerged the Placido disc, and the Placido disc gave rise to a number of machines, including the photo video keratoscope, the video keratoscope, and currently the corneal topography systems. Corneal topography systems also evolved in 20 years. And the first topography system that I've had the good fortune to work on was a Placido based system way back in 2004. Now you seem to have newer machines which are called the next generation of diagnostic equipment from the point of view of diagnosing keratoconus. And each of them is touted to be better than the other. And each of them has an advantage of being able to measure the posterior surface of the cornea, where we are told by manufacturers as well as experts that keratoconus is detectable first on the posterior surface rather than on the anterior surface. Now, each of these machines has its own strengths and its own weaknesses. So, we're not going to go into the details of what these are exactly. But just to suffice that in a debate about which is the best topography machine out there, when anybody asks me this question, I ask them a question about if you have a choice of cars that you would rather drive, which do you think is the best car in the world? And just like there is not going to be any consensus on this, similarly, there never will be a consensus on what is the best topographer out there because most good topographers actually do a pretty good job in diagnosing keratoconus. And for that matter, a simple Placido disc topographer that gets you from point A to point B, in fact, suffices in doing the diagnosis of keratoconus quite accurately. And when someone also asks, what is the earliest clinical sign of keratoconus that you can detect in the clinic? The answer is not just corneal topography, but in fact, if you do a good retinoscopy on these patients, you probably will be able to detect keratoconus as early as the best topographers right now. So, moving on from what keratoconus is, the second question is who gets keratoconus and why do people get keratoconus in the first place? Well, once I asked my fellows that why don't animals get keratoconus? Is it because they can't rub their eyes, or is there a better reason why they don't get keratoconus? Well, the only obvious answer is because we don't do corneal topography on them. They might have keratoconus, but we will never know. Keratoconus as a disease condition has also challenged different groups of scientists. And right now, the consensus seems that there are genetic as well as environmental factors that determine who gets keratoconus and how it progresses with time. So, going a little back in time, and I found this interesting analysis of a 48-year-old clinical and epidemiological study of keratoconus that was published in 1986, about 40 years ago. And this is from one county in the US in Minnesota. And the numbers in the graph that you see towards the right side indicate that the number of keratoconus patients seen per year was on an average less than 10 in their entire county. So things have changed quite a bit from then, and the average prevalence of keratoconus was considered extremely low, and it was not considered a disease that is really worthy of spending too much time on. But then publications started to emerge from around the world, and meta-analysis that compiled all these publications started to report higher incidence prevalences of keratoconus around from different parts of the world. And a distinct pattern seemed to emerge. It seemed as if keratoconus that occurred in countries that had a predominantly Caucasian population wasn't very common, but keratoconus that seemed to occur in countries that had a predominantly Asian population, the prevalence of keratoconus was much, much more frequent. This continued, and on publications that came in from Japan, the US, and parts of Europe, the prevalence of keratoconus was reported to be somewhere in the tens per 100,000 patients. So, actually, quite rare. But publications emerging from India, in the Middle East, as well as parts that had a predominantly Asian population, seem to show that the prevalence of keratoconus was much more common than what we are expected to what we are trained to expect, with some studies showing prevalence rates as high as 3% in the general population, which is an exceedingly high prevalence rate for keratoconus. So it seems as if from epidemiology studies of keratoconus seems to be on the rise around the world. It seems to be commoner in certain geographies and in certain ethnic groups. And it also appears to present at a younger age in Asians as compared to Caucasians. But data from India has been relatively limited. So, there have been some interesting studies that have emerged from India. There's this recent publication from Mumbai that screened high school children, and from here it seems as if the prevalence of keratoconus in high school children, at least, was about 3.5%, which is relatively high when you consider that 3 out of every 100 children in a high school has keratoconus. Similar studies have emerged from other parts of the world, especially in Africa, primarily in Kenya and Rwanda, where it seems as if the prevalence of keratoconus is relatively high, especially in younger age groups. It seems as if high school children are more prone to have keratoconus than children who are older. Interestingly, it also seems as if keratoconus can present with relatively normal vision, and this publication from a series of optometric clinics in Australia said that almost 50% of keratoconus patients had vision of 6 by 6 at their first presentation to the clinic, which means that keratoconus cannot be diagnosed just by visual assessment. So what we did back in LV Prasad Eye Institute, where I come from, is we started categorizing all cases of corneal diseases that we saw in the last 10, 12 years or so, and we started to measure how frequent these were. And the dark red bar that you see down here is a summation of all the ectatic disorders that we see every year. And you see that the numbers have started to go up every year. So what we did was we started to collect all the data from patients who came in with diagnosis of keratoconus, and over the last 30 years, we seem to have seen about 20,000 plus patients of keratoconus. Two-thirds of these patients were male, one-third of these patients were female. And the prevalence, at least the clinic-based prevalence of keratoconus, just seems to keep going up in every 4-year period that we started studying from the 1980s. And in fact, it seems that almost three-fourths of all the keratoconus patients that we've ever seen in the last 30 years seem to have come to the clinic in the last 8 years or so, which is a scary metric. Another interesting metric is that the average age of presentation of the patient with keratoconus also seems to be falling. And the average age right now of a patient who presents to the clinic is closer to 20 years than to 30 years that it was almost 30 years ago. Another interesting statistic is there seems to be an increasing number of patients who are using contact lenses as compared to surgical intervention in keratoconus. And this probably has to do with the introduction of several new kinds of contact lenses. And the introduction of each of these new types of contact lenses saw an upswing in the number or the percentage of contact lens users. This seems to have led in a reduction in the number of patients seeking surgical intervention. And with the advent of collagen cross-linking has become the most frequent surgical procedure that is performed for keratoconus as compared to corneal transplantation that you can see going down in numbers over the last several years. And the graph here that shows the different kinds of reasons why we do corneal grafts at LB Prasad Eye Institute, the first part of the graph shows the corneal ectasia patients, and you see that the numbers seem to be going down in every 5-year period that we've been observing these patients. This also seems to do with the advent of collagen cross-linking somewhere in 2009. Once collagen cross-linking became available, the number of transplants that we had to do for patients, especially the penetrating variety, seemed to be going down. And even the partial thickness transplants seem to be coming down in number. And it seems that keratoconus, at least clinic-based data, seems to say that it accounts for about 7% of all corneal disorders that we see right now and about 7% of all transplants. The incidence seems to be going up quite significantly over the last 3 decades. Age at presentation is getting lower. Contact lenses and cross-linking also seem to be reducing the need for transplants. But here are some more interesting statistics. The age of which keratoconus patients walk into the clinic, more than 80% of these patients are between the ages of 10 and 30 years. So it is a disease that occurs in the younger population, as all of you already know. And interestingly, it seems to be a problem that afflicts people from the higher socioeconomic demography. It also seems to be more common in urban geographies as compared to rural geographies. And something that all of us have suspected all this while is there also is a significant history of eye rubbing and a significant association with allergy in these patients as well. In fact, there also have been a series of articles published by Damien Gatinel, which seem to show that cessation of eye rubbing seems to reverse the progression of keratoconus with time, also highlighting the impact of allergy as well as eye rubbing on the progression of keratoconus. And in fact, another big data study that was published from LV Prasad showed that the highest incidence of ocular allergy was between the ages of 3 and 11 years in children who came to the clinic, which is just before the onset of the peak of keratoconus, which seems to show that keratoconus does have a significant correlation with ocular allergy as well. Another interesting metric that we've also seen is that patients who tend to present in younger ages also tend to have more severe keratoconus when they present. In fact, patients below 10 years seem to present with more severe keratoconus as compared to patients who are slightly older. Females also tend to present with more severe keratoconus to the clinic, and patients who come in from rural geographies also seem to present with more advanced disease as compared to patients who come from urban geographies. So, what is the visual impact of keratoconus on a patient's or a person's development? It seems that a significant percentage of keratoconus, in fact, more than 20% of keratoconus, do present with moderate to severe visual impairment at the time of presentation. And keratoconus also seems to have a significant impact on the quality of life for patients similar to those who have macular degeneration and even worse than patients who have glaucoma. And also, patients who have macular degeneration and glaucoma tend to develop these later on in life, whereas keratoconus develops much earlier in life. To summarize what we've learned over the last 30 years or so, it seems as if keratoconus majorly occurs between 10 to 30 years with a male skew. It seems to be more common in the upper socioeconomic strata and in urban areas. It seems to result in severe vision impairment in close to 15% of patients who present to the clinic. Females have a more severe disease at presentation, and patients who come from rural settings seem to present with more advanced stages, probably because of lack of access to infrastructure. And I think one of the most important things about keratoconus is the fact that we are trying to do less and less transplants in these patients, and cross-linking and contact lenses seem to be game changers in reducing these numbers. There is an increasing suspicion in detecting keratoconus in patients who are young with refractive error, which is probably helping us pick up this disease a little earlier. Early cross-linking and monitoring of these patients is the center stone of reducing the need for transplants in these patients and also picking up the condition at an earlier stage that you can treat. So now keratoconus seems to be moving from the realm of being a clinical condition that you wait to diagnose in the clinic to more of a community health problem that you need to go out there and screen for before it becomes severe enough for the patient to come to the clinic. And it seems to have significant vision impact as well as long-term impact on children, not just on their vision, but their overall psychological development, as well as their quality of life with time as well. I think it is very important for all of us to pay a lot of attention to detecting keratoconus early before it starts to impact vision. And I think the rest of the presentation and my colleagues today are going to be speaking to you about tools that will help you to detect as well as to diagnose keratoconus earlier than what we are used to and how we can go about that. So thank you very much for your attention to this little introduction about keratoconus. I'll first ask my colleagues, Dr. Nilima or Dr. Pallavi, if they would like to add anything further before we move on to the questions. Yeah, thank you, Dr. Joshi. Thank you, Dr. Balakrishnan. So I'll just take up some of the questions from the Q&A and try and see if we can answer these. Dr. Fatih asks, how early can corneal topography detect subclinical keratoconus compared to slit lamp and keratometry? I think the term subclinical keratoconus means that it cannot be detected on the slit lamp. And subclinical keratoconus means that it only can be diagnosed using an instrument. And so corneal topography is probably the most reliable as probably and also the earliest documented way in which you can diagnose keratoconus. And I would suggest that it is better than keratometry because it also measures the peripheral part of the cornea, whereas keratometry only measures the center part of the cornea. Second question, Dr. Fatih, which topography indices, example, Bellin-Ambrosio D-index posterior elevation maps, are most reliable in distinguishing form thrust keratoconus? Uh, I'll answer that a little differently, and I believe that most topographers will be able to diagnose keratoconus if you can read the topography well enough. Placido disc topographers are almost as good as Scheimpflug topographers. There is increasing evidence that any posterior changes in keratoconus will almost always have some change on the anterior surface in topography. And if you ask me about a particular index, every machine has an index and every machine has a number of criteria by which you detect keratoconus. I think in the pentacam, the posterior elevation maps, the D index, it's a summated D index that probably has the greatest sensitivity in detecting keratoconus. Next question, how do tomography approaches like Scheimpflug, OCT compared to Placido-based systems in sensitivity and specificity? I think I just answered that, and I like to believe that we would like to have Placido-based systems compared to the best of the Scheimpflug as well as the OCT-based systems. The reason why I say that is because most Scheimpflug and OCT-based systems are located in the clinic, and they help in diagnosing keratoconus or keratoconus suspects in the population of patients who want to undergo refractive surgery rather than screening for keratoconus. And it probably is here that they have a leg up over placebo-based systems. But in diagnosing keratoconus, I think the placebo-based systems are pretty good. What role does artificial intelligence or machine learning currently play in enhancing keratoconus detection from topography data sets? Well, all of us know that artificial intelligence is probably going to make most diagnostic equipment or most ophthalmologists or most eye care practitioners who read out printouts from machines redundant, and very likely that new AI algorithms coming out in the future will not only help you to diagnose keratoconus early, they probably are also going to help to prognosticate what will happen to keratoconus in the future as well. I hope we've answered that question to your satisfaction. If not, let us know. Uh, Hassan Ibrahim Sabri asked about what about in Africa and keratoconus. I can't claim to have a deep understanding of the prevalence of keratoconus in Africa, but as much as I've read, it seems that Northern Africa, as well as Central Africa, especially in Rwanda and Kenya, the prevalence of keratoconus is relatively high. It is believed that, especially in Rwanda, keratoconus is the second most common reason for visual impairment following cataracts, and that means that we have a big problem on our hands. Uh, Next question, what is your frank opinion on the no rub, no cone hypothesis of keratoconus etiology? I believe that keratoconus has a multifactorial, I think, approach to its detection as well as its progression. There seems to be a population that is predisposed to developing keratoconus, but if they don't rub, they may not develop the disease. But if they rub, then the disease tend to develop as well as progress faster. So it seems as if there are components of somebody being predisposed genetically, and there are components of people who, because of eye rubbing, tend to have disease that progresses faster as well. Dr. Mace Mohammed, cross-linking indications. Cross-linking indications is progressive keratoconus. Anybody who has progressive keratoconus should get cross-linking because it is the only reliable way in which you can prevent progression of keratoconus. And patients who come in who are young with keratoconus also deserve to be cross-linked because they inevitably will progress with time. Currently, our indications that anybody who is aged less than 16 years gets cross-linking in their first visit, and anybody who has progressive keratoconus beyond 16 years also gets cross-linking. If corneal thickness is less than 400 microns, can we do cross-linking? If not, then what should be done? I think I'll answer that in a roundabout way. If there is benefit of doing cross-linking and you think that the patient can reliably wear contact lenses or spectacles, then the thickness of the cornea really does not matter. You can do cross-linking even in thinner corneas. There's several techniques that have been described for that, and I think it is possible to cross-link these eyes as well. What are the minimum signs to detect keratoconus? The minimum signs should be that you should be seeing topography changes, primarily asymmetry on corneal topography, which will help you to detect keratoconus. Uh, Dr. Hafiz Kaleem, how many times can we do cross-linking on a single patient? Well, my record is 3 times. I don't think we've cross-linked anybody more than that, but that's just one patient. And cross-linking in a younger patient, it's believed that the effect of cross-linking tends to wear off with time, and you might need to do a second cross-linking, especially if you're cross-linking someone who is extremely young.
So, hello everyone. I'm Dr. Nilima. I'm from LV Prasad Eye Institute, Hyderabad, and today I shall be discussing our school screening program designed for early detection of keratoconus and the process of how we went about in the development of this program, our learnings, and where we would like to take this program in the future. So, as Dr. Praveen has explained already, so keratoconus is a disorder which has early onset. It is progressive and chronic in nature and can lead to significant visual impairment. From a pediatric perspective, vision plays an important role in the childhood development process. Pediatric keratoconus has a more severe clinical presentation, more rapid progression, as well as higher association with vernal keratoconjunctivitis and atopy, and higher risk of developing complications like corneal hydrops as well as corneal opacity. Unfortunately, the exact population-based prevalence of keratoconus has not been well documented so far, and we have multiple reports in the literature with varying incidences described, ranging from 0.16 to 4.79%. It is, however, well documented that in the Asian population, there is a higher incidence and onset at earliest age, as well as higher incidence of a severe stage of the disease by the second decade. And this is where screening comes in, and this is what we hope to prevent by detecting the disease early in the susceptible population. Apart from its impact on the vision, it also has a significant impact on the quality of life of the child. So there is a strong correlation between a worse visual acuity and a lower vision related quality of life, as can be expected. But what is surprising is that even in early stage of keratoconus, where the corrected distance visual acuity where might be preserved, a decline in the vision related quality of life has been noted. This has been attributed to reduced contrast sensitivity, which is crucial for reading and facial recognition, which are tasks which are of extreme importance in the school going age for their academic as well as scholastic performances. And it has also been seen that when keratoconus is associated with other comorbidities such as vernal keratoconjunctivitis, the dip in the vision related quality of life score is even more. And therefore, it is safe to assume that keratoconus is not just an eye disorder, it is a social and developmental condition that has a significant impact on the child. It also has a significant economic burden in addition to everything else. So, one particular study showed that on an average, care for a patient suffering from keratoconus costs $24,168 more than the care that is required for a person with myopia. And almost half of this, that is around $13,000, goes into the cost of a penetrating keratoplasty and addressing any post surgical complications that might result from this procedure. And when an analysis was done on all the factors that have an influence on the lifetime cost, the only one of clinical significance that was seen was the probability of needing a penetrating keratoplasty. And this is again where early screening as well as detection of the disease before it goes into the stage where it needs a penetrating keratoplasty assumes paramount importance, because you are hoping to arrest the disease at an earlier stage, thereby decreasing the economic as well as the psychological impact that it has on a person's life. Furthermore, the average annual individual cost for a patient with keratoconus is almost 3 times that of a patient who suffers from refractive error. There's also a significant impact on income and productivity. In fact, in a cohort of patients in the CLEK study, it was reported that 11.5% of patients reported missing work due to keratoconus. And from a pediatric perspective, this would mean that school hours are missed, tests are missed, and opportunities are missed, which would greatly contribute, greatly impair their progress ahead in life. The good news here is that keratoconus is a disease which, if it is detected in the early stages, we do have a treatment available to arrest the disease progression. So corneal collagen cross-linking is most optimal and disease stabilizing when it is done early in the course of the disease. And because the disease course is more aggressive in children and they're more likely to have advanced disease at presentation, it is essential that the disease is detected early so that cross-linking can be advised. And this also becomes of increased importance when keratoconus is associated with atopic diseases, because in these scenarios, simple changes such as the avoidance of eye rubbing would help in preventing further progression of the disease. And what we have to emphasize here is that delayed detection in these cases leads to diminished efficacy of intervention, leading to visual loss and further impairment of the quality of life of the child. So with all these factors in mind, we came up with the concept of this school screening program for early detection of keratoconus. In this program, our objectives were fourfold. So we wanted to conduct eye health programs in schools in rural and urban areas and provide refractive correction for all those who are found to have refractive errors, as well as to screen the school children for keratoconus and provide appropriate referral services to tertiary care centers, as well as to screen the children for allergic eye disorders. The project is planned at 3 locations, that is Hyderabad, Vijayawada, and Bhubaneswar in South India. And we aim to screen 50,000 children in Hyderabad and Bhubaneswar and 100,000 children in Vijayawada. Our total project team consists of 45 field assistants, 20 optometrists, and 3 local coordinators. This is a prospective cross-sectional observational study. And the process that we are following as a part of the study includes an initial vision screening by the community eye health workers in the schools. And after the vision screening, the child is taken to the keratoconus screening station, where the child undergoes a comprehensive eye evaluation along with a slit lamp examination and a corneal topography, as well as a semi-structured questionnaire, which aims to detect any associated risk factors or comorbidity, such as allergic eye disease. If there are any abnormalities that are detected in this screening, in any stage of this, then the child is referred to a higher center for further management. If there are abnormalities detected on vision screening as well, then initially a refraction is done to see if if there is an improvement in the visual acuity, and if there is an improvement in vision, then spectacles are provided, and if there is no visual improvement seen, then the child is referred to higher center for further management. So we use a semi-structured questionnaire to screen for any associated allergic disorders. And these are just a few questions that are included as a part of the questionnaire. So the main aim of the questionnaire is to assess whether the child has habitual eye rubbing or any other features of allergic eye disease, such as itching, redness, etc. And what is the frequency of these symptoms that the child has, and if the child is taking any treatment for that, as well as how is it affecting his scholastic performance as well as his ability to attend school and contribute effectively to the school activities, and what would be the effective strategies through which we can prevent the further deterioration of the allergic disorder. When it comes to screening for keratoconus, it is well known that corneal tomography through Scheimpflug imaging or the pentacam is the gold standard because it provides imaging of the anterior as well as the posterior surfaces. It is sensitive and allows for early diagnosis, but it comes with multiple limitations of its own because of its high cost, and it is also not portable in nature. Therefore, setting up the pentacam at each of the school's screening locations is a challenging task. It also needs skilled technicians as well as clinical skills to interpret the results. Therefore, as a part of a pilot screening program, while we have included Pentacam to screen the school going children, it is not a feasible solution in the long run to scale this to multiple geographies. And we had to look for alternate methods in order to ensure that the screening goes at a faster pace while not compromising on the accuracy of the screening. And this is where we came across the a smartphone based screening device. It's a Placido ring based device, and it's attached to the smartphone, and therefore it requires no extra equipment and is much more affordable than the Pentacam. It does not require highly trained technicians, and the images that are captured by the device is analyzed by the processing software immediately, and it gives easy to interpret results which can be interpreted by the technician on ground performing the scans, therefore giving a more effective as well as faster referral pathway. So in order to ensure that the results that are given by the smartphone-based topographer is accurate, we subjected the device to 2 rounds of in-clinic validation. It was initially validated in normal eyes in a cohort of 300 healthy eyes who had presented to our refractive clinic to ensure that the keratometric values that are coming are at par with the gold standard. Following this, we also validated the device in keratoconic eyes to ensure that the keratometry values as well as the accuracy of diagnosis that the device provides is can be compared to the current standard of care. Furthermore, in our school-based screening setting, around 500 children have already completed topography with the InstaCase handheld device, and it shows high correlation with the clinical gold standard with a good test-retest reliability. So the scan with this device is fairly simple and easy to perform. Once the Myers reflected from the Placido disc on the corneal surface are focused, the device captures the image on its own. And following this, it also gives the report, which gives both the keratometric values as well as the heat maps. And it also gives an analysis of what is the provisional diagnosis in the sense of whether it is a normal eye, a keratoconic eye, or a keratoconus suspect, which ensures that it is easier to interpret and can also be referred to higher center by the vision technician who is performing the scans. Our early results in the school screening program has been very encouraging. We have completed around 47,000 screening for around 47,000 children. And on the initial testing, around 13.5% of them have been diagnosed with abnormalities, and 10.7% of children we've completed the topography. And there's an incidence of around 2% of children with abnormal topography, which includes both keratoconus suspects as well as those with borderline abnormalities or a thick cornea or a borderline posterior elevation. And there's also around a 6% incidence of allergic eye diseases. So in this study, we also learned that it is possible to conduct a large-scale school screening program within school hours, and there is a high degree of participation and acceptance among children and teachers. And what has also been encouraging has been to pick up cases of asymptomatic keratoconus with good visual acuity, which would have been missed otherwise. And it has been integral in this process, the role of the smartphone-based topographer, which increases the access to advanced diagnostic methods without compromising on the accuracy of the diagnosis. And we've had some challenges along the way, mostly to do with the logistic part of it, because screening a large student population with the limited time that we have during the school hours requires multiple visits at times. And then sometimes in cases, differentiating true keratoconus from false positives has been a challenge, and training as well as retaining screeners and creating the awareness as well as acceptance among the parents and teachers. And finally, the most important thing is to integrate them into the continuum of care and ensuring that the referrals reach higher centers and decreasing the amount of dropouts. where do we plan to take this program forwards? We have to ensure that we scale up this program and to expand the reach of the program to more schools and regions, and to develop structured follow-up mechanisms to ensure that the referral pathway is solid, and that this is not just a way to detect an abnormality, but it is also a way to ensure that the child is integrated into the system and there is a comprehensive follow-up care that is provided to the child. This also helps to build a large data set for epidemiology and risk factor analysis to further provide targeted treatment for those risk factors, thereby decreasing the incidence of this disease. And the link between the innovation and scale in this process has ultimately been the smartphone-based topographer, because of its portability and because it's compact and usable in any classroom setting. And because it can be operated by vision technicians, it reduces the dependency on ophthalmologists. It is also operates at a high speed and thereby enabling us to screen a large number of students within the limited school hours that we have. It's also very cost effective when you compare it to the standard of care. So that is the conventional pentacam device is around $40,000 when compared to around $4,000 for the smartphone based topographer, which is around which makes a difference of around 10x, which can be used to screen a higher number of children. And finally, to ensure that this project is scalable and sustainable, and it helps to ensure that it can be integrated into the national school health programs. So to summarize, keratoconus is a disorder that has a significant impact on the economic as well as the psychological profile of the child, and requires school screening programs for early detection of the disorder and to ensure that the children receive comprehensive care. Thank you.
Hey, Dr. Balakrishnan, that's an excellent summary of how we can go into the community and potentially detect keratoconus earlier than we are doing currently right now. So I think that also showcases a cost-effective way in which keratoconus can be detected, because awareness of keratoconus is relatively low in the community right now. In
Yeah.
fact, even among the medical fraternity seems to be quite low. So I think screening programs are an excellent way in which we can detect keratoconus earlier and also to intervene earlier as well. Great. So, Dr. Nilima, I'm going to pick up some questions from the Q&A to try and see if we can answer them, along with
Sure.
questions that are more specific to your talk as well. So, we have a question about can keratoconus at its severe stage benefit from collagen cross-linking procedure, or are there any appropriate management for severe keratoconus? Uh, what do you think? Severe keratoconus, cross-linking, or anything else?
So it depends on the topography parameters. So if it is a very advanced case of keratoconus, there is a cutoff for the corneal thickness, a minimum thickness that needs to be there for cross-linking to ensure that there is no endothelial toxicity that develops as a complication. So that is something that has to be considered. And if it is a very advanced case of keratoconus, which is not amenable to cross-linking, the patient might have to be subjected to a keratoplasty procedure. Otherwise, contact lenses are, of course, another way of visual rehabilitation that can be provided.
Yeah, very nice. So, I think a very pertinent question emanating from your talk. Uh, Andrea Mirkovic wants to know what proportion of keratoconus cases are we missing in routine practice? Uh, what do you think?
I mean, most of the cases that we found are cases which had normal to moderate visual, mostly normal or early vision loss. So most of these cases, I feel like around 50 to 60% would have been missed unless if the school screening program was there. So because all of the cases that we are detecting are not they're not having any active visual complaints. They're comfortable with their spectacles, or they've never seeked care for their complaints until this point. So a very large proportion, I would say, is being missed
Yeah.
out.
Are there any specific high risk groups that you think we should screen for in particular? You alluded to school children as being a potential high risk group because the age of presentation of keratoconus is quite low. Any other populations do you think we should screen for as well using corneal topography to be able to detect keratoconus early?
If they have a history of any systemic atopic disorders, asthma, eczema, anything like that, that would be a high risk group, because they would have these symptoms of, like in our study as well, we have found out that a lot of them do have systemic atopy, which are associated with ocular symptoms, but for which they are not on any active medications, and they have abnormal corneal topography as well. So that would be one group. In addition to that, it has also been seen in multiple studies that if there are any hormonal changes like PCOD or a thyroid disorder, or if they're undergoing treatment for infertility, those are all high risk groups. In pregnancy, so those are high risk groups which should be screened to see if there is any early changes.
Very nice. So, you also said that you think it would be a good idea to make screening for keratoconus as part of a national program to piggyback on school screening. How many years away do you think we are from making this happen?
I hope in the next 5 years or so it would be. I hope with the data that we get from this study, we would have we would be able to influence some policy that would help us take a step in that direction.
But next up, we also have a very, very interesting talk by another esteemed colleague, Dr. Pallavi Joshi. Dr. Pallavi Joshi is a cataract, cornea, and refractive surgery specialist. She practices in the Shankara Eye Hospitals group of hospitals, and she's based in Bangalore. And she, along with her colleagues, have worked on a very interesting innovation that would help to screen for keratoconus. And we'd like to hear from Dr. Joshi how they went about doing this. And then we can ask her more questions at the end of the webinar. So, Dr. Joshi, over to you.
So the next few minutes, what I would be covering about is our early learnings with portable topographer based prototype. We would like to share with you all is the learning curve in the construct of the smartphone based keratoscope prototype of keratoconus. So as you all are aware that keratoconus is a progressive disease, and it is a disease which is an ectatic condition, which if it comes in advanced stages, usually is associated with apical scarring, acute eye drops, and also with opacities. And the only option then left is surgeries. So just to take care, the most important aspect is early detection and treatment to arrest this progression. We all know, as the previous speakers have spoken, that the prevalence of keratoconus is very high, especially in the Asian countries. We have seen it is 4 to 5 times more, mainly because of the temperature as well as allergic components. And the investigation modalities were discussed. And we know that the modalities are mainly the placidose-based, like the opticon, keratron, or we have the tomographies like the pentacam, wavelight oculizer. And also now we have the OCT-based topographers. But these all are non-portable and very expensive. And hence, early diagnosing these things with patients who are from a middle or lower income population becomes very challenging. So this is inaccessible to larger section. That is where we started thinking of how to go about. So it was probably around COVID that at Shankara, we collaborated with a very efficient team of Microsoft research team, and we attempted to create a smartphone-based keratoscope prototype. So we basically tried to create a prototype, and we took the scientific and ethics clearance to go ahead with this. And we compared this design and setting what we made with the Keratron-based topographer. And apart from this, we also validated whether this was good enough to use for seeing whether it can pick up the disease. So what I will be discussing is that, yes, as we know that when we see a quiet lake and a duck moving around, we know that it is very quiet. But what happens is the paddling that happens under the water. So I'm just showing you all that, yes, before anything comes up, like now the Insta Casey, which Dr. Nilima showed you, actually has been the thing which has started with this smart Casey. So we had to go through the prototype evolution and also look at how the smart Casey could be modified. And also we had to see at whether it could pick the disease, and most important, whether we were not missing the disease and whether it could be repeated in anybody, whoever used it. So if you can see this picture, you can see actually that this all of us are masked up. This is during the COVID time where the journey began. Here we termed our prototype as Smart Casey. So the first thing what we had to actually decide on was, we know that we are doing it on the Placidus base. So what type of Placidus design we use? We went through the ellipsoid variant, we went through the planar, and then the conical. So what was very interesting is we didn't create different of these. We used a simple 3D printed conical, Placidus base, like what you can see here, because the other was too very bulky to be used on the patient, and the planar ones were not capturing the periphery. So our Placidus design was this type, which was put into this kind of a cylinder. It had 28 rings and a length of around 70 millimeters. And the smallest ring closest to the camera was around 4 millimeters. And the one which was away was 15 millimeters. So what did we do is, since we were all having very clear idea that we wanted a very cost-effective prototype, we used a lot of technology and we simulated the Placidus prints on this kind of simulated model, where we used a spherical model of 7.8 radius and tried to get this Myers. So with this, we were not doing repeated creation of the prototype, and we were able to come up with what we wanted just by using the simulation structures. Okay, once we came out with the Placidus, what were our challenges? So here, the greatest challenge what we had was about the tilts and offset. Just to tell you what was this is, like, see, any topographer, as all of us know, if the picture is captured properly, then we are able to pick up the disease. But a wrongly captured picture actually may also give us an erroneous disease which may not exist, which is very much wrong, as well as it is very anxious for the patient. So here we found out that when we were checking that the principal axis as well as that of the reference axis of the eye had to be matched. If they are not matched, then we are getting erroneous, false keratoconic pictures. So how did we tackle this was, we realized that we could do this by actually including something in the Smart Casey app, where we brought in a small cross and a central square, which without alignment would not take up the picture, so that we're very sure that the captured picture gave us the correct capture and the both axes corresponded to each other. So just to show you all, how was this picture of Smart Casey? If you can see here, this is the simplest Android phone which we have used. And here, this is LED 10 lights which are used. This was a butter paper which we have used here, and the cone, and this was snugly fitted to the camera. You will be surprised to know that the total cost of all that we have actually used is not more than $483 for the whole of this device. Once this was plugged in, you can see the rings very nicely inside. And this is how the smart app workflow was. It was attached, and we went in for a new test where an IP number for the patient was given. And once this was done, we kept it over the patient's eye. You can see this square of green, what I was talking about, and her hair. This is a virtual cross, which ensured that we didn't have problems of tilts or offsets. Once the capture was done, then this image was checked real time for exposure, quality, as well as to see whether it has the correct Myers that have been taken up. So a real-time check was something very fabulous in the machine, and we need not repeat if the images were not good. So once this was done, we were able to then convert this image into a grayscale, and that grayscale was converted to an image enhancement. And this later, using the arch step method and the Zernike, was converted into heat maps. So this is how the whole process of an image that was captured as just Myers was converted into a heat map, which we all see as a topographer. Amazingly, this we were able to do it on the smartphone based. So, but was that enough? We were very happy that, okay, we got some pictures, but we definitely wanted to know whether it was good enough to pick up and was it accurate as that of any standard. So we again took our institutional help, and we went ahead with a prospective study where we took around 202 pairs of the patients' pictures, and they were converted into 101 from the smart KC, and this also from the Keratron. And we had rated them as keratoconus, non-keratoconus, and suspected. And this was both of the tangential and the axial map, and given to the ophthalmologist to rate them. They were randomized to minimize the bias. We had the initial challenge that when we gave it to them, we had an inter-observer variation, because we had this greatest challenge was the SIM K1 and K2 and the heat maps were not matching, because we had something called as the K values were actually initially computed for the 5mm zone. But once we corrected to 3mm zone, we were able to convert that inter-observer variation. And after correction, we were able to get a good sensitivity and specificity with our smart KC as much as that of the Keratron. So if you see this picture, actually you cannot know which is from the big bulky machine, that is the Keratron, to that of the portable. They are nearly comparable. The only thing which you can differentiate is this V mark, which you can see here, which we were able to cover it up by the gap filling. So to conclude, actually the smart KC achieved a sensitivity of 94% and a specificity of 100%, as compared to Keratron, which had a sensitivity of 100%, but specificity was less. And this is very important. As we all know, a screening device should have a specificity which is very good, and also sensitivity above 90, so that we do not miss the disease. And we also found that the SIM-K values, that is a simulated K, which we obtained from the smart KC, were closely resembling that of the Pearson's correlation with the Keratron. And the inter-rater agreement also showed a good correlation. So prior studies had been done of low-cost smartphone-based keratoconus diagnostic solutions. However, they had very limited amounts. And this, what we went through, was actually end-to-end implementation of a smart cases system. And what was amazing was it is a very low cost, and it was comparable to that of any other standard machine. And the important aspects here which we overcame was by using an app which was a real-time feedback, which was correcting the quality of the image picked, and high quality Myers were only captured from a handheld device. So with this, though results seem promising, we believe that evaluation with a bigger sample size and from different demography was needed before the real-time deployment. This was in 2022 when we actually have published this as a prototype thing. Later, actually, this thing went ahead in the form of a product, which now has actually come out as a Insta KC. And we had only made this up for a single device, but we expected that any camera which has specification of 12 MP should be able to use this app very comfortably. And the data collection, which has to be done in a broader way. So with this, actually, it highlights that, that the learning curves are there with this, but we are very gratified that, it had a good sensitivity and specificity as compared to a standard Keratron machine, which is used as a screening device. So thus a prototype device called Smart KC needed a larger sampling. And we also assumed, as someone was asking about, using the artificial intelligence and deep learning, we could also add on a lot of things to this device and come out with specific algorithms wherein we can also give a printout of whether it is a keratoconus, whether it is suspect, so that it can be used for a wider population. The whole intent of creating this prototype was we wanted it to reach to the people where it didn't, and where we had to screen, like people who were not able to reach to the hospital. So basically, this was the intent, and we could make it a prototype with this much. These are the recent photos which have been shared by the Insta KC, where now it has come out with a well-defined print paper with both axial tangential maps, as well as it has a kind of which it shows whether it is keratoconus, non-keratoconus, or a suspect. So I would like to conclude by giving acknowledgement to the fantastic team of Microsoft research people. And it was a real first time experience where clinicians and technology can come together and create wonders. Dr. Kaushik Murli, as well as Dr. Anand, my colleagues who have been a part of this whole journey of Smart KC. So thank you, everyone.
So, I mean, there are a few questions in the chat as well, but before we go there, you probably would have evaluated other available handheld topography systems when you were developing your prototype, the Smart KC that eventually became the Insta KC right now. So, what would you look for in a topography system that is handheld? I mean, you spoke about mobility, you spoke about cost, you spoke about accuracy, sensitivity, and specificity as well. Other than that, what else would you look for if you have to use such a system in the field as well?
As I said, see, for any screening, Dr. Praveen, we know that we should be able to definitely pick up a disease. So, yes, as I said, the specificity is very essential so that we are specifically picking up this disease. I would still say when we spoke about this, it's a screening tool, not a diagnostic tool. So this is basically used only to pick up something which is a red flag, which obviously has to go ahead with a finer diagnostic assessment for progression. So what if you ask me what add-on should be ideally, is that we should also have where we can compare the data in these mobile smart applications, where it can be at the field level only be able to compare whether there has been progression or no. And obviously we know this is a placidos based, and yes, we do pick up only the anterior aspect, but the ideal way also, if you ask me, we should also come up with something where we would be able to pick up the posterior flow changes also. So these two are something which we have to look at. So an algorithm which can actually do an automated progressive analysis and probably pick up a subtle diseases also.
Very interesting. So, Dr. Nilima Balakrishnan, you have seen the use of a portable topographer in the field as well, and you've seen how a traditional topography system that is well recognized, like the Pentacam, being used. What advantages do you think a portable system has over a traditional topographer, other than what we just spoke about from the cost, from the mobility point of view as well?
I mean, the speed with which it acquires the images is one thing that, and the ease of the how it can be operated, right? So, because Pentacam setting up the device at different places, that is a challenge. And the Pentacam actually, like, it's again, like Dr. Pallavi said, for a clinic-based setting, what we're looking for in a clinic-based setting and what we're looking for in screening are completely different. So all the parameters that a Pentacam gives, may not, the person who's doing the screening at the schools or wherever we are intending it to be used may not know how to interpret the value. And in that setup, just having a much more simpler way to read the scan and just having like a single diagnosis or like an indication that this is a suspicious topography that needs further evaluation, that would be more helpful at that sort of a level than a finer, more granular way of like detecting the individual abnormalities. So for a screening based setup, that is something that it's very easy to interpret. So it the analysis as well as the interpretation can occur in very fast way.
Yeah, I think some very interesting points there, like both Dr. Pallavi Joshi and you mentioned, taking a pentacam to a screening program is like taking a gun to a sword fight. which might be a bit of an overkill, and you don't really need that level of precision for a screening tool. And screening tool needs to be very sensitive, like Dr. Pallavi mentioned earlier, so that you don't miss any keratoconus patients. And you also have to have high specificity, so you don't refer patients who really don't have keratoconus as well. And like you mentioned, very important, ease of use on the field and the speed at which you can use a device is very important too. Because if you have a heavy machine that you have to lug around, set it up, and then the time that is required to screen, if it is going to be long, it is not going to be a very effective screening method. So if you have something that screens quickly and you can keep moving from place to place, that is probably by definition the ideal screening method as well. So thank you for that. There are a few questions in the Q&A section, and it would be great if we could discuss these a little bit. Question for Dr. Pallavi Joshi. When should we recommend a corneal topography? For subclinical keratoconus, when there is no sign, you do not know when you need a corneal topography. But should we do a topography screening for every patient? Is the question.
In my opinion, topographic screening for every patient is an overkill. In my practice, what normally we do, especially in the pediatric, because that's the age where we normally see, is when we are finding that the K values are very high. When I say high, more than 47. Second, if we find that they are not having, the best corrected visual acuity is not improving, and even though you may not pick up a seizure reflex, and family history of keratoconus, definitely if the family members have, that's where is one more time where I would definitely go for a doing the topography. And people who have recent increase in the power, which normally we don't expect after the age of 21, or an altered or changed axis. So I feel clinical history and change in the refractive error and unusual axis are something where I would definitely think about going. I normally would not say for everybody. So these are my four most important where I would do a topography definitely.
Yeah, it's a great summary of where you would suggest a topography to be done, which patients are potentially high risk, and also which signs clinically from your clinical acumen and years of practice will help you to suspect that somebody has keratoconus. Like, great suggestions. We have a very interesting question for Dr. Nilima next. Why do you target school-age children but not infants for early detection of keratoconus? Because logically speaking, you want to detect it as early as possible, right?
Yeah. So when it came to devising a program, the highest incidence of keratoconus, the earliest incidence as well as the earliest incidence of allergic eye disease has both been reported in the 5 to 15 years of age group, and the earliest signs of keratoconus have also been reported in that age. We don't have a lot of reports of very early onset of keratoconus. So if we screen earlier than that, there is always a concern that we might be missing out, and these children might still go on to develop keratoconus ahead in life. It's just that it is not in that age group where they have started developing the signs yet. And we also wanted it to be at a stage where the early signs have started, but it has not affected them yet, affected the vision, and it is still amenable to therapy. So that way, the school going age was a sweet spot that we could hit, and we could also screen a large number of children there and start the referral loop and the management options before it started affecting their vision and further performance.
Yeah, great. And also, infants are probably not going to cooperate for
Yes,
topographies, in
that's
addition to
that's
that. But like Dr. Nilima said, I think what is important is that the average age at which keratoconus develops now seems to be in high school children. That seems to be the earliest onset of keratoconus. And that is the population at risk that you would like to screen. And as far as I remember, the earliest documented case of keratoconus is in a 4-year-old child,
40.
at least in publications. I don't think any younger children have been diagnosed with keratoconus. So that's the age group. I mean, you need to screen children who are at risk. So children of consanguineous parents, or if one parent has keratoconus, the parents typically ask, what age should I screen my child from? Typically, the answer is whenever they start to become cooperative for a topography. On an average, that is around 7 years or so. Very, very unusual for someone to develop signs of keratoconus before 7 years. So that would be the average age. I think that's Dr. Pallavi Joshi. There's a question about what is the price of a handheld smartphone-based topographer and how do you send it to Bangladesh?
See, to answer that, Dr. Praveen, as far as what I understand, I was involved, or our hospital was involved up to the point of creating the prototype. And now I think the InstaKC is probably, taken care by the other group. I think Dr. Nilima also mentioned it is around something 4,000 US dollars is the total amount for that. How it reaches and
Yeah.
all that, I think they should contact probably the company which has now converted this prototype into the product.
Dr. Nilima, do you have any further information?
4,000 US dollars is what the cost of the device is. And the company will be able to explain if they are able to ship it to Bangladesh.
Yes, so I think right now it's commercially available. At least there are several types of handheld topographers that have been described in literature. There's several patents also for handheld topographers as well. There is one from Japan, one from Brazil. But I think as far as I know, there are only three handheld topography systems that are mobile. There is one from the company called ISIS, which is a Placido-based topography system that is usually used quite widely in field trials. There is a second one from Oculus that also is a sort of a mobile topographer that can be fitted to a slit lamp. The one that Dr. Pallavi Joshi and Dr. Nilima have been referring to is called the InstaKC. It is from a company that is based in India called Remedio, and I think that's the price that they were referring to. Great. So, question for Dr. Pallavi Joshi. Can the smartphone topography detect changes of the posterior cornea?
Um, the smartphone based topographer, now what has been created is a topographer. So as for now, it only is able to pick up the changes on the anterior curvature because it is purely based on placidos. So the reflection is occurring on the anterior surface, and we are not using any Chamfleck or slit scan. So presently this machine or the smart KC cannot pick the posterior float changes. No.
Yes, great. And Dr. Nilima, question, are there any more ways to detect keratoconus early other than what we've discussed today?
Other devices are described like the Corvus ST or the epithelial mapping on the OCT, but those are all expensive ways of detecting. Even changes in aberrometry has been described in cases of keratoconus, but they're difficult to do on a large scale. So the accepted method is still topography or a tomography that would lead to early detection.
Dr. Pallavi Joshi, do you do cares in your practice?
Yes, I do. Yeah.
So there is a question about cares. Do they need cross-linking pre-surgery, or does cross-linking need to be combined with the surgery is the question.
Yeah. So there are two ways of seeing at it. So in my cohort, we have done both. There are some patients in whom we have already done cross-linking, and then we do the cares. That is the additive keratoplasty, where we are adding a small allogenic corneal ring segment inside. And otherwise, those who are already having a progression and in whom we feel they are very fit for the cares procedure, I first do the cares and then we do the cross-linking in the same setting.
Very interesting.
Yeah.
So, question for you, Dr. Nilima, is how to identify keratoconus in the school vision screening program, because there is no special team for detecting keratoconus in school camps. So, camps conducted at low cost. How do we go about this?
So we can look at the history if there are any associated risk factors like allergy, eye rubbing, itching, etc. And the vision if there is any refractive error, uh, as well as in refraction if that is something that is available in like the camps that they're referring to, then scissor reflex would be something that can has the potential to pick up. Ideally, if it can be combined with a topography, that would give it greater value and lead to picking up much more number of cases. But if not, then scissor reflex is still a good way in which we can provide some amount of screening, or a keratometer, and in cases with high astigmatism can be referred for further evaluation.
Yeah, also, if you have a team of like maybe field assistants or healthcare workers, do you think they can be taught to handle the topography system to make sure that the cost is low when you're doing a school screening program?
Yeah, so that is the ultimate aim is to ensure that whoever is doing the screening, any form of screening program, this can be seamlessly integrated into that. So the way to ensure it is to make sure that the device is easy to operate and use, so that it can be put into the screening like more conveniently. And the device that we have described, so it focuses on its own. Like once you focus the image, it will capture the image on its own and give the reading. So it doesn't have a steep learning curve, so it can be put into use quite fast.
And that will reduce your costs as well. And
Yes, in
you can
training
have
and manpower.
yeah. And you can have a clinician maybe look at the topography that is coming out of the screening device. And do you think the screening device also has an evaluation for keratoconus that it can give you automatically, or does it always require a clinician to make that decision?
So this device does have it gives you that analysis, like it goes through the cloud processing of the image captured, and it gives you an analysis if it is a normal eye, a keratoconic eye, or a keratoconus suspect. So that distinction it is able to make. So even if they're not able to interpret the scans or the values, then just with that one distinction, they can make the decision whether the child needs to be referred or not, or needs further evaluation.
Makes sense. So, Dr. Pallavi Joshi, you spoke a little bit about how AI has been incorporated into the screening protocols for keratoconus. So, there's a question from Dr. Al Zafri. Will AI prediction models be able to forecast the exact timeline of ectatic progression in individual patients as well?
That, as I think we all understand, AI is what we are actually training. So if the AI has to predict that, we have to feed a lot of data, which we have in retrospect. Like, interestingly, in our hospital, we are actually doing an analysis of those children who come to the pediatric clinic, where initially they are not even having keratoconus. And then after 4-5 years, we see suddenly how come they, become keratoconic. So I think in future this can be done, but provided we have that lot of data that has actually been fed into, and then the deep learning the AI does. So I don't think it is not possible, but presently I think we need a lot of data for that, because exact prediction of okay, this is going to be 6 months when he'll progress, 7 months. I think that is little difficult, but we can give a tentative this depending on the severity probably. If that is fed in, maybe we could come out with that. That's my opinion.
Yeah, very interesting. Do any of you have any further comments about the future directions of screening for keratoconus that you think we are going to embark on, say, like in 5 years or so, compared to what we're doing right now?
I mean, ideally, it should be incorporated into like health camps are conducted at like workplace to ensure that they are in optimum fitness. Similar to that, there should be some form of checkup and in that is done in the school level as well. And keratoconus should be a part of that evaluation to ensure that we're not missing out on anything.
What do you think, Dr. Pallavi, as well? Do you think in the future we're going to have more screening and less clinic-based programs for keratoconus?
Yeah, I think the future is in for it, and I will not be surprised if a patient comes that I have self-screened myself and have had this disease. So please look in, doctor. And in a way, see some things where technology gives us an added advantage where, because I know we all being doctors, we are into a preventive medicine where we do not want the disease to in the first place happen, where the awareness comes in. Second, if the disease has already happened, the earlier it is picked, it is better so that we don't end up with something that is not necessary to progress. So definitely I'm very optimistic, and I think, yes, as Dr. Lima rightly said, what the need of the hour is definitely every school, because schools have eye checkups, but they don't do that detailed screening the way it is necessary. So maybe I think, teachers training with probably provision of these kind of portable machines would go a long way, and we would be able to pick up them at an early stage. So I think, yes, the future is in preventing the progression and early detection, definitely.
You think that in the near future we're going to have these detection systems set up in malls that people are going to go and do
Could be.
self-screening, and then
Yeah, yeah.
saying AI model in the machine is predicting that my keratoconus is going to develop in like 2 years. So do something for me, doctor.
Yeah, we should be all braced up. Yes.
Yes. So, quick question again. Just last few set of questions before we close. Post collagen cross-linking, do you see central haze, and if you do, how long do you think it lasts, Dr. Pallavi?
Yeah, there's two different things. Like now, this is a pure clinical question where
Hello?
haze. Hello, am I audible? Dr. Praveen?
Yes, go on, please.
Yeah, Dr.
Yeah,
Pallavi, you're
yeah.
audible.
So, corneal haze versus there is something called
Yes,
as
yes.
after doing cross-linking. We see something called as like, stromal stress lines. So these usually is just an indication of healing of this, stroma after exposure to UV rays and the cross-linking. This thing usually goes off by around 6-8 months. But sometimes you can have a deeper haze or literally a scar. So it's somewhere, already the keratocytes have become more fibroblastic. This can occur either because of the person's the some technical issues, excess this or a thinner cornea where overdose of the power has occurred. Such scars usually last also a little longer. But otherwise, the natural haze, what we see, I have seen majority of them disappearing by 6-7 months. In children, it takes a little longer sometimes. So yeah, they do.
And any typical steroid regimen when you see this kind of haze in these patients? Do you continue steroids for longer, or does it really not matter?
No, I'm not. I normally don't use steroids after the first 6 to 8 weeks, at least not until the patient has some allergy or inflammatory eye, where yes, basically we see these hairs and scars more when the eye is more inflamed, if they have associated allergies. So maybe for that I would have given steroid, not for the hairs. At least I don't use prolonged steroids. How
Great.
about you, Dr. Praveen? Do you give steroid for a long time?
No, generally our protocol is that steroids we use for about 6 weeks post
Mm.
cross-linking. And then we just stop steroids unless there is a component of allergy as well. Short course.
Yes.
So we have one last question in the chat. Uh, so should all children, Dr. Nilima, of adult keratoconics be automatically screened for signs of keratoconus?
Yes, they should, because there is a strong genetic component as well, in addition to the genetic component that the risk factors have. So by both ways, there is an increased risk. And ideally, everybody in the susceptible age group should be screened. But if that's not possible, then if there is a family history, then definitely yes. That would indicate that there is a higher index of suspicion to be kept, and they should be screened at an earlier age and yearly to see if they're developing any signs.
Yeah, that's great advice for all eye care practitioners who are taking care of keratoconus patients, because it's not just the patient but the progeny that probably should be screened for early detection of keratoconus as well. So congratulations, we have no more open questions. We've had a great webinar where I think we went through an overview of the evolution of keratoconus, so to say, over the last 30 years. It's very interesting that you are, as a medical practitioner, living through the greatest changes in the disease, both detection as well as in therapy. And also, I think we had some very interesting insights about how you can use a mobile handheld topographer in a screening program to be able to detect keratoconus earlier than what you would normally detect in the clinic. And then I think Dr. Nilima also spoke about how the future is more about detecting keratoconus in the field, like an epidemiological condition, rather than waiting for keratoconus to develop and present in your clinic. And Dr. Pallavi again spoke about the evolution and the thought process and all the hard work that went into developing a mobile topography system that currently has helped in the screening of keratoconus in schools right now. So hopefully we'll see a lot more of this, and we'll see a lot more utility for a mobile handheld device, especially with the advent of home care in a big way, and also in hopefully become part of school screening protocols as part of national programs in the future as well.